morning, ladies and gentlemen. I'm in charge of introducing you to the anti-angiogenic therapy. And first of all, I would like to point at what tumors may benefit to this, from this therapy. Of course, the NET are a good target because they have the hallmark is the high vascularization as an average. And this is among the imaging criteria to diagnose it. But how are the vessels structured in these tumors? The capillaries in normal islets have fenestrations in their membrane, while in neuroendocrine neoplasms, the cells have no fenestration at all, and is fully covered by pericytes, as you can see with the immunohistochemical staining with the alpha smooth muscle antigen. And this is a peculiarity of the capillaries of neuroendocrine tumors. And as you know, the classification that Guido Rindi and Gunther Kloppel just changed, but we cannot apply to old papers. We had 4 classes identifying benign, certain carcinomas of different classes. This is just to say that in 2003, the group of Skozek showed that the higher the class and the lesser vessels you find in tumors. And this is actually also accompanied by a lower performance of the patients. And then a couple of years later, these data were confirmed, and so the macrovascular density is lower in tumors with a high class, WHO class. Again, a couple of years later, a group in Japan showed the same thing, that the higher the class, the lower number of vessels you find. And what is very interesting is that also they showed that if you find low vessels, low number of vessels in low classes, they are a prognostic parameter, actually. And they classified and gave the grades not like the ENETS is doing with the proliferation index grades, but just with morphology. And they pointed to the presence of solid areas into the histology. Of course, let's say solid sheets are the poorly differentiated, but they pointed out one interesting thing, that wherever you find nests of solid areas, you are recognizing tumors with a lower performance, clinically speaking. And this is shown here, their grades, is the presence of solid areas. What is interesting is also that the epithelial proliferating cells are mainly found in these areas. They showed with double staining, CD34 identifies the endothelial cells and Ki67 proliferating cells. And what they did show is that the endothelial proliferation index is a prognostic parameter that means how many endothelial cells are proliferating inside the among the endothelial cells present in large sheets area, in the solid areas. So to make a long story short, what happens is that in normal islets, you have the vessels that are smooth, thin, regular, and they become in well-differentiated tumors. They are thicker, but still they retain their regularity, and they are fully covered by many pericytes. When you go on low vessel densities, so on higher classes diseases, you find that the vessels are thick, are unbranched, are less. You find many buds, but still they are covered from pericytes. Now, what is the angiogenic strategy? Is just to hit the VEGF and VEGF receptor pathway, actually. And you can do this directly or indirectly. So directly, you can hit the VEGF using monoclonal antibodies, the bevacizumab, for example, or you may hit the VEGF receptor with tyrosine kinase inhibitors. And this is what I will talk about because of the mTOR pathway, which is the indirect way of acting also on this pathway. Dr. Yao will talk just after me. So I will just point to a few studies. The first one is this from Dr. Yao, actually. where the question was, do we may use bevacizumab, the monoclonal antibody, and so close the tap of the blood, or first the everolimus that blocks the mTOR pathway. And then if we have to combine what we can do with that, what is the sequence? As you can see, the result was that bevacizumab alone was able to reduce the blood flow of about 50%, while the blood flow was not really reduced, only 12% by the everolimus. And then if you add in sequence after the bevacizumab, you have the everolimus, you get, again, a very good result, which is much better than on the other way around. So the result of the study shows that we have to use maybe first to close the tap, and then we may add anything else. But this is the best result you can have. On the other hand, using inhibitors, there are many trials ongoing, and many studies of phase 1 or 2 or preclinical are pointing that this may be an interesting way to, and Professor Olberg also showed you that. I will only mention two things. First, TKI inhibitors do not only inhibit VEGF, but also PDGFR for sure, and then others also. And the use, I will only show one phase 3 trial, which is this one that has been already shown by Professor Olberg, that is very interesting because it was designed to recruit, I think, many more patients, but it was stopped because it was functioning. And as you can see, the primary endpoint was the progression-free survival. It was working, and actually the progression-free survival was doubled with respect to placebo, and this led to the approval by the European Commission of this drug for the unresectable or metastatic pancreatic net. Now, what is interesting actually is that this does not work very well when the tumors are highly proliferating and when you have metastatic disease. So we have still to be careful and to understand how to use it properly. But the rationale to use VEGF inhibition also came from preclinical studies on the mouse models that has the insulin promoter, is a transgenic mouse, that has the insulin promoter and the SV40 antigen that gives you the possibility to have at the precise timing tumors, vascular tumors, and advanced tumors. So you can treat these mice with different trials at different times. So if you want to see, as it's the clinical way, you show the big tumor, and you can make a regression trial to try to work it out if that drug or combination of drug may work on this. I will only use this example to show you something about the metronomic chemotherapy. The metronome, of course, gives you an unvaryingly regular rhythm. And this is the basic of the metronomic chemotherapy, which is the chronic administration of chemotherapeutic agents at a low dose, which is minimally toxic, and then you give no interval for the cancer cells to recover after the hit they've had. And the most interesting protocol, let's say, that may be designed is usually this. You give a maximal tolerated dose, which is a standard chemotherapy, and then with a very small interval, you give a metronomic drug used with usually a multi-target inhibitor has been proposed in this study on the mice with very low doses in the metronomical way. Now, what happens? It happens that actually this allows you to hit the pericytes that detach from the capillary vessels, and that they become more prone to be hit by the chemotherapeutic agent. And this is shown here, where you see the green are the pericytes, that they are really reduced along the time. And you have a reduced pericyte coverage, and so the cells become, the endothelial cells become more sensitive. But actually, to make a long story short, this is not the only thing that happens, because you are hitting for sure the vasculature, but you are also hitting the cancer cell with metronomic therapy, and there is evidence that you are also hitting all the immune-regulating cells that inhibit the immune response to the cancer, usually. So if you take away, for example, the Treg, which is a particular group of T cells that inhibit the response to the cancer, it is possible, and it has been shown, that you may enhance the immune response to the tumor, and so you can control it. So metronomic therapy is hitting more than only vasculature. And if you know that VEGF is not only letting the tumor endothelium grow from where they exist, but VEGF also is released and calls the cells from the bone marrow. These are hematopoietic cells that will form the dendritic cells, the T cells, or whatever, that goes into the tumor and go with the tumor to form the tissue tumor, but also the pre-endothelial cells. Now, the basic of the metronomic therapy is that if we hit malignant cell, I will kill her because she's not able to recover the DNA, while the endothelial cells has no problems because she knows how to repair DNA, and so I will hit her and I will be tranquil. If I hit her, I will kill her forever. But there are new things coming out that cancer cells may also become endothelial cells. So in a cancer, the endothelial cells are those coming from the very same vessel that is there, well differentiated, of course. There will be the majority of cases, but also there will be cancer cells becoming some of the endothelial, and we know that there are different tumors, from lymphomas to gliomas or whatever. We have endothelial cells that have the same genetic abnormalities of the cancer cells. So, and then we have also endothelial cells coming from progenitors from the bone marrow. So what we know, what is the target? We do not really know for NETs. And we need to understand this to know what is our enemy to hit. And so the mixture of using and hitting the endothelial cells, the pericytes, the hematopoietic cells that will form all the dendritic cells and T cells that make up the surrounding of the tumor is still a work that we have to do. Thank you very much.